Hi, everyone. My name is Ted Reese, and I'm the Director of Development for the Penn State Heart and Vascular Institute. In other words, I'm your fundraising guy. A few moments ago, Dr. Aziz made the mistake of asking me if I'd like to say a few words to introduce the Atnip lecture in vascular and endovascular surgery, and I said, oh yeah, give me a microphone, I'm happy to do that. Because I want to take the opportunity to personally thank Dr. Robert and Chantal Atnip for their generosity in establishing this lectureship. I've been here at Penn State for a little over 6 years, but I've known the Atnips for many more years than that. And so when I came here, Dr. Atnip was very kind in helping me orient to the College of Medicine and to Penn State Health in my role in philanthropy. So it means a lot to me to be able to welcome all of you to the third Atnip lecture. When Dr. and Mrs. Atnip were already en route to come here for the lecture, we learned that Dr. Matthew Eagleton, who was the planned speaker for today's lecture, had fallen ill. And so Dr. Aziz quickly pivoted to create the presentation you're going to hear today, where he and Dr. Radke will be joined by Dr. Atnip and also Mrs. Atnip at some point to talk a little bit more about a stellar career as an educator, as a healer, and as a researcher. So it's my pleasure now to introduce the Chief of the Division of Vascular Surgery, Dr. Faisal Aziz.
All right. Thank you, Ted, so much for your kind words and for organizing all this. Thank you so much, everybody, for joining in this Friday afternoon to honor Dr. Atnip and hear some words of wisdom from him. Personally, most of you know Dr. Atnip, but for those of you who do not know him, Dr. Atnip was trained at Mass General Hospital in his surgical training and joined Penn State Hershey Medical Center in 1985. And going back in time, those were the times when vascular surgery was relatively a new specialty. Not many people knew about vascular surgery. Not many institutions had vascular surgery divisions. So I believe that our institution had that foresight into future as to what is going to happen. And when Dr. Atnip was recruited here, vascular surgery, there was only one vascular surgeon here at that time. And I think for the following next 3 to 4 decades, he was the face of vascular surgery at this hospital. And I think anything in vascular surgery specialty that we see today, not many people know that how much hard work must have gone through over the course of past 4 decades to build this division, to recruit people, to establish those criteria for vascular labs, starting one of the oldest vascular labs in the country, and to start something which our institution was not aware of it before. So we're all very honored to have Dr. Atnip and Chantal Atnip with us today, and we're very thankful to your gracious gift for the institution to start this lectureship. As a brief introduction, this lectureship was started about 4 or 5 years ago, but due to pandemic, we couldn't start it. Our first speaker a few years ago was Dr. Julie Freischlag, who's the CEO and Dean of Wake Forest University. And the second last year was Dr. Melina Kibbe, who's the Dean of UVA. This year we were going to have Dr. Matt Eagleton, who's the Chief of Vascular at Mass General Hospital, to give his talk today. But unfortunately, he fell ill. And we had the option of either canceling it or listening to Dr. Atnip himself, because after all, it's Dr. Atnip's lecture. So thank you all for coming. I'm going to ask Dr. Atnip to come over and say a few words, and then we'll have a brief conversation with him. My request to everybody is that I wanted to have a conversation style, so please feel free to ask questions or ask comments as you see fit. Dr. Atnip.
Thank you very much for attending today. Today was supposed to be the day that you would have the privilege of meeting Dr. Matt Eagleton, the chief of vascular and endovascular surgery at the Massachusetts General Hospital, where I trained for 7 years, a number of years ago. Dr. Eagleton, as you know, was unable to come today due to health problems, and therefore unable to deliver the address. I also did my vascular surgery training there, and quite a few years ago, 1978 to 1985, under the tutelage of such wonderful mentors as Dr. David Brewster and Dr. Clement Darling, who were the vascular surgeons at the MGH during the years that I mentioned. Also, there was Ashby Moncure and many other people who took the time and interest to train me in those skills and those endeavors. After graduation, I went to work as a vascular surgeon here at the Penn State Hershey Medical Center. Any of those mentors could have authored the words that Dr. Eagleton was planning to deliver. All of them were physicians and surgeons and humanists of the finest and highest order. It was the ultimate privilege and opportunity to be in those places at those particular times, and I wish all of you the experience to dwell in the long shadows cast by such gifted and dedicated souls. As you already know, our profession requires many traits and skills: physical coordination, agility, at one moment surprising strength, and the next moment a delicate and exacting precision, each action demanding the exercise of pure and total attention and concentration to the actions at hand. As for wisdom, it should likely be considered the most difficult attribute and quality. It is an entity that can be quickly recognized but is difficult to define. I would assign it as perhaps the most desirable but elusive of the qualities we are considering. It can escape us against our will or clothe us without our recognition. In my career, from medical school to retirement, I have been constantly blessed and been the recipient of numerous mentors who gave of their knowledge, insights, wisdom, and most importantly, time toward the molding, crafting, advising, and educating me to the received wisdom and the education to relieve sickness, restore wholeness, and to join my colleagues in the advancement of medical science and the betterment of humanity. Those who came before us have given their all, and we must follow in their shadow and ensure that knowledge lives on. I will close briefly with the motto of the University of Chicago, where members of my family received their education. In Latin, it is Crescat Scientia Vita Excolator, and in English, let knowledge grow from more to more for the enrichment of life. Thank you.
So my first question, Dr. Atnip, for audience here, many moons ago, you were trained at Harvard, at Mass General. Talk us through as to how was your decision, what went in your mind to join Hershey Med Center, where vascular surgery was not even established as a big specialty? What went in your mind, and looking back, what would you change anything?
Well, it's a little late for that, but I felt very privileged to train at an institution like Mass General Hospital. I didn't really know what to expect. I knew I would be working hard and that there would be great demands on me, but I also realized that the final product of that would be skills that I would be able to do what I had wanted to do for a long, long time, which was to be a physician and a surgeon. Mass General has always enjoyed a very fine reputation and has turned out many, many outstanding physicians over the years. And it was an extreme privilege for those 7 years in Boston to associate myself with folks of such achievement and quality. Originally, I wanted to be a heart surgeon, but it seemed like everybody wanted to be a heart surgeon in those years. So I thought, well, maybe let's try something different. And I found out there was a new specialty known as vascular surgery, which involved operating on blood vessels, but not the blood vessels of the heart. So that seemed to satisfy some of my desires without feeling that I was doing something that everybody else was going to do too. And a lot of people didn't even know what vascular surgery was at that time, or what vascular surgeons did. But basically it is the care of the blood vessels in the human body outside, excepting the heart and the brain. So except for the blood vessels inside the head and around the heart, everything else belongs to us in the circulatory system as vascular surgeons. And I didn't really know what to expect, but I learned right away that I had made a right choice, whether by intention or just by good luck. And I was working with some people who were the people who had invented vascular surgery and were defining the techniques and developing the knowledge that needed to be done for that. So fortunately, it was exactly what I wanted, and I enjoyed it greatly. It's difficult, it's tedious, there is a lot of risk involved in it. You are shutting off blood flow in different vessels, fixing the calcium deposits and other things that were blocking those blood vessels or causing aneurysm in the blood vessels to expand, and being able to correct those things to rectify the circulatory problems and restore blood flow to those different organs in order to prevent horrible things like gangrene and amputation of the legs and those sorts of things. And the thing that I found that was even more interesting than heart surgery, than I thought heart surgery would be, was that vascular surgery involves all the other blood vessels except the brain and the heart. And so you've got a lot of different things to do and a lot of different variety. You're not operating on one thing. One day it could be the femoral artery in the leg, the next day it could be the brachial artery in the arm, then it could be the aorta, and so you're operating all over the body, and that was very satisfying and rewarding to me. And so I did that and wound up here in Hershey. I considered looking for jobs at a variety of different places. Some of those places were appealing to me, but I wasn't appealing to them. So like all jobs, you have to find the right match of the employee and the employer. And after looking at quite a fair number of places, I wanted to stay in New England, but that wasn't going to work out. So that being the case, I at least wanted to be on the eastern seaboard. I was born in Tampa, Florida, and lived in the southeast, for all of those time. I wanted to stay in the east and kind of on the eastern seaboard. And I was at a meeting, a medical meeting, and I happened to encounter two people. I overheard them talking about vascular surgery, and so I butt into the conversation. And one of the people there was John Waldhausen, who was the chair of the Department of Surgery here, and the other one was a man named Brian Thiel, who was an Australian surgeon who had come to the United States to practice this new field of vascular surgery. And just by overhearing that conversation, I kind of butt in and told them who I was and asked what do you do at Hershey, Pennsylvania, and do you need help at Hershey, Pennsylvania, and I'm looking for a job. And it turned out that they were looking for a candidate, so I just kind of, again, blundered into, the right place at the right time. And a few weeks after that conversation at the meeting in San Francisco, I went to Hershey to see what was going on and to talk to Dr. Thiel and Dr. Waldhausen in more detail. And it seemed appealing to me by its location, and both of these folks seemed to be very trustworthy and seemed to be speaking honestly and candidly with me, and seemed to be the kind of people I would want to work with and kind of help start Division of Vascular Surgery. And that's how things played out. Going to central Pennsylvania was certainly different from being in the Northeast and a city like Boston, but you adapt to things and try to make the most of the opportunities that are presented to you. And any qualms that I might have had were very quickly dispelled by the personalities of Dr. Waldhausen and Dr. Thiel. And they were happy to have me, and I was very happy to work with them. And so I've been here ever since then, and have not regretted it in any way, shape, or form. It's provided a lot of opportunities to me. It gave me the opportunity to take care of a lot of people who entrusted their lives and limbs to me, and it's been very rewarding in 1,000 different ways. And so here I am. And I wouldn't change anything. It's been interesting to live in central Pennsylvania. Ultimately, we moved out to Idaho because of children and babies and things. Life happens. And now we live in the Northwest. But it's been a great pleasure to come back to Hershey from time to time to see how things are going here and to meet and talk with my friends and my mentors and the people who did so much to set me on the path that I have followed these many years. Thank you.
So Dr. Atnip, when you came here as a new surgeon, what things did you do to be successful? Like, did you set goals for yourself, or were there different things for the first couple years of your career that you wanted to do that you thought would make you a successful surgeon?
Mm-hmm. Well, I was kind of full of myself when I came here. And I learned how to do general surgery as a resident at the Mass General Hospital. And then after that, learned how to do vascular surgery. So I wanted to do both of those things. I wanted to do everything I could do. And they offered me the opportunity to do that. They said, we want you to do general surgery and vascular surgery. So I had the opportunity to do a lot of different kind of things, a lot of different kind of procedures on a lot of different kind of people. That was very appealing to me. As time went by, the Hershey developed its own department of general surgery, and so at some point I stopped doing general surgery and handed that over to them, which seemed to be the right thing to do, and just began to concentrate completely on the vascular surgery side of things.
I'm going to pull Mrs. Atnip in as well. So you have a unique perspective, being a spouse of a busy surgeon and being a mother of a physician woman as well. So from your standpoint, talk to us about your experiences and what you have advised for all of us here, because I think, all physicians and all healthcare providers in this room will rely heavily on our spouses. How was this experience for you, and what lessons you learned?
So Robert and I got married after his first year of medical school, and we just celebrated our 50th wedding anniversary this summer. So we've been together a long time. And as I want to say, some years were longer than others. But as a wife of a very dedicated, driven surgeon, medical student, I mean, every stage of Robert's life has been, he's always striven, whatever, to be the best to do the best that he could in academics, in surgery, in helping people, in supporting his colleagues. And I, as his wife, am a very independent human being, and I would say that all of you, your partners in life, have got to be very independent human beings. We cannot be sitting at home waiting for our husband or our wife or our partner to be able to be free to come home. We have got to fulfill ourselves. So our daughter, our youngest daughter, is also a family medicine doctor out in Boise, Idaho, with 2 small children. She has a 4-year-old and a 1.5-year-old, and hence we're out there being grandparents, which is delightful. But her husband has made the same decisions that I made, is that I am a partnership, and he is so supportive of everything that she does, and he has a full-time job, 2 small kids. We all are partners with our husbands, wives, partners, and we've got to be independent, supportive, and basically as goal-driven as my surgeon husband, in our own way. And so I took on the house and home. Robert, bless his heart, made every effort to be around as much as possible. And the girls respected that and appreciated that, especially as they have gotten older. They really took our relationship, that was stated at our 50th, that we were a partnership, and they recognized that, that we are, it's a joint effort to be a surgeon, a spouse, and a partner. So it's, God bless every one of you and your other person that is in your lives. So, yes.
And if you mentioned during your opening remarks about mentors, and you've been a mentor for me for a number of years. What in your mind makes a good mentor? What do we have to do to help our mentees?
The first thing, of course, is you have to want to be a mentor. You have to have that drive to share what you know with other folks, and to call upon the experiences that you've gone through and the things that you've done, and share those with other people in order to basically make them like yourself, which sounds somewhat selfish, but I think in professions and in most any endeavor, we all at some point meet people that are mentors that we have tremendous respect for, and we want to be like those people, and that's how we become professionals or whatever it is that we do in life. We encounter people who take an interest in us, who encourage us, who teach us, who kick us in the butt when we need to, and who go out of their ways to give of themselves to help other people achieve their goals in life. And I've run into a lot of people and a lot of mentors to whom I never really will be able to express the thanks to them for sharing their skills and their knowledge and their experience with me to help keep me on the road to the goals and to the places then that I want to be. I've been extremely fortunate in that way, and I've tried to be a mentor and give back to those who have come under my direction and under my tutelage. and that's been a very rewarding thing.
I do have a question. Next question is that, I think I recently did a bypass on one of your patients, and you'd had the bypass on the other leg. So he asked me, is it going to last as long as Atnip's bypass? I think my honest answer was no. So I think the key thing when I look at your career is the relationship, your ability to form these relationships with patients, be it that patient, who used to come to see you every single week for dressing changes, or be your colleagues that, would have the highest degree of respect for you. What do you think is, for us, for all of us here, what's the magic formula to establish the relationships with the patients and our colleagues?
I think that's a really important point. It's easy to be a doctor in the sense that you can acquire the knowledge and the skill to diagnose diseases, to look up in the books and see what drugs they need or what procedures they need or what ministrations they need to be able to heal and get better and get well. And it doesn't necessarily involve or require that you establish a close relationship with your patients, as long as you prescribe the right drugs for them or perform the right procedures on them and do those procedures correctly. And all of those things are essential. And for some physicians, it's the mechanics of it that is what they do well, which doesn't necessarily mean getting deeply involved with the patient. But for me, I want to give them the right drugs and do the right procedures on them, but it was always much more fulfilling for me to get to know my patients in some way or another, and to show them that that the care that I provide to them is in part technical care or medicinal care, that it's also personal care. And I would say that that was by far and away the most fulfilling part of what I've done as a physician over the last X number of years. Sometimes it was easy to do that. Sometimes it was difficult to do that. I certainly have been shooed away from the bedside by more than one grumpy patient. But I've also had wonderful relationships with many, many, many patients whom I was fortunate enough to be able to help. And that to me was an element of being a physician that I would not want to omit or leave out or minimize. And I think, depending on the circumstances, that patients really appreciate that. Some don't, some want to, and you have to respect that. But in the big picture, the practice of medicine involves intimate interactions with people who have significant needs that you have the knowledge to help fulfill those. And I think I've been able to do this as long as I did, and to work the hours and do what was necessary, simply to get to know my patients and to always make it clear to them that I care about what happens to them, not just what happens to their feet or what happens to their aortas or what happens to some other body part, but to try to help them toward better health as a long-term goal, and to be there for them as long as they need me and as long as I am available to help them.
So just know that we've been now in Boise for about almost 4 years. And occasionally I'll see Rob has picked up the phone and he's still checking on some of his long-term patients, seeing how they're doing and making sure that they're getting the right care here. Just saying, we're checking up on you. So the other thing that is that the relationships that Rob has had over the years was important to our daughters as well, because he would come home with stories, and we can be in a restaurant, or in one case we were in Disneyland, Disney World, and all of a sudden across from a cafeteria someone says, "Doc Atnip." It's one of his patients. So the girls have experienced this all their lives, the fact that Rob has had these relationships with his patients. And I think that influenced our daughter's decision to go into family medicine, because she considered doing some other specialties, but not ones that would have a long-term relationship. Like she looked at orthopedics, and that you fix a problem and they're gone. And so she really appreciated the idea that she would have a patient base that she would have a relationship with over time. So just thought I would throw that in.
Thank you. Thank you. I still hear from my patients from time to time. There's one of them in particular, one of those patients that you never forget, who had a very, very difficult hepatobiliary surgical problem. And as I mentioned earlier, I did general surgery early in my career. And this was a very challenged, a young man who was really, really sick with biliary sepsis and needed his whole right upper quadrant renovated, so to speak. And we stay in contact with people. I hear from him, once every few months. It's not like we call each other, every week, but usually at least once or twice a year, one of us will pick up the phone and call the other one to see how they're doing. And my patient, fortunately, has done well. He had some relapses in the early years, but I think everything is kind of settled out now. And I'm always happy when Taylor calls me and gives me a good report on how things are going. And so the satisfaction of what we do in the practice of medicine is part of it is in the moment, but part of it is for the long run. And I think that those are some of the most gratifying situations and gratifying things that physicians can do.
I'll share a story. When I was a young attending here, I had a difficult patient, and I went to Dr. Atnip, and I told him the problem. So he said to me, "What are the options?" So I said to him, "Option this, option this, option this." And he says to me, what's the hardest and the most difficult option? And I said, "Well, it's option D." And he said, "Well, that is the right answer." And I felt like as young faculty member, I learned the hard lesson, not only in medicine or surgery, but in life. I think given multiple options, hardest option is usually the right option. And I think that principle has led my personal life in a very different direction, because when you're looking at multiple options, what the right thing to do is probably the hardest thing to do as well. What is your advice we have so many residents and new young faculty members as well. What's your advice for young residents and faculty members, how to be successful?
Well, I certainly agree with you that oftentimes the right thing to do is the hardest thing to do, and that's one of the most, I think, difficult parts of the practice of medicine, is to bypass what will be a relatively easy or simple thing to do, or maybe a quick fix to handle that problem with a kind of a short-term solution, where in your heart of hearts that it's not going to work for very long, and that what you really need to do is take a big breath and say, okay, this is going to take me hours, and I'm going to have the patient in the hospital for days, and it may be months or even years before this problem really settles down and the patient can get back to a normal life. But if you don't do that, if you try to take the shortcut as most of us have found in life, when you try to take the easy way out, it ends up being the hard way out. And instead of taking up less of your time in the long run, it ends up taking up way, way, way more time than anybody wants to. So it's better just to do it up front, take a deep breath, and just plunge in and do what you know needs to be done. And don't listen to the voice that says, take the easy way. Listen to the loud voice that says, you know what to do, just go ahead and do it.
So Dr. Atnip, what were some pivotal moments in your career that you think helped shape you or maybe change the way you thought? Were there any, or were there anyone in particular that you remember?
One of them was the patient with the hepatobiliary problems. That certainly was a good example of that. There were others. There certainly were very difficult vascular cases. Didn't work out too well at first and had to require reoperations, and patients seeming to respond well to surgery, but then within weeks or months, the problem recurs or complications are discovered. And now you're doing redo surgery, which is much more difficult technically for the surgeon, and of course much more difficult for the patient, who has to undergo another procedure, which is going to be more difficult because you've already been in a certain part of the body doing things. There's going to be scar tissue. Exposure of the area is going to be difficult. It's much more likely that you'll injure the other normal structures. And I've had some of those operations, and then some other operations that patients come in that present very, very difficult problem, and you would do anything to be able to hand that patient off to somebody else. And one of those, really one of the most difficult cases that I ever did, perhaps the most difficult, was a patient came into the emergency department one evening, sent in from jail. This was a young man, say in his early 20s, who fortunately had chosen a life of crime. Had been shot a few times and survived that, then had been sent to prison, where he was recovering in the prison infirmary. He'd had an operation before initially with gunshot wound in another facility. He was kind of languishing in the other hospital where Billy wasn't getting well. They decided to transfer him to Milton S. Hershey Medical Center, and of course, 11 o'clock at night, I was on call. I took the phone call and listened to what the referring doctor was telling me. You know, my heart was sinking. It's like, well, I know what I'm going to be doing all night long, but it turned out to be very, very difficult because he had abdominal surgery before. Much of the damage that he had sustained from the gunshot wounds were in his right upper quadrant, so where there's a lot of things. Duodenum, there's the gallbladder, there's the biliary tract, the rest of the intestinal tract, liver, and so I took him to the operating room because his right upper quadrant was very, very badly scarred down from the previous operations and the sequelae of the gunshot wound. Of course, you know, it was midnight. It wasn't something I could put off to the next day, where I would have, you know, lots of colleagues to help me with it. It was me that had to do this. And so I took him to the operating room, bit by bit, little by little, lysing adhesions, separating one structure from the other, identifying the normal structures, trying not to damage those structures, getting through all the scar tissue down to report of hepatitis, where I found out that he had a fistula between his portal vein, biliary system. It was just a mess, and I was felt this is impossible. But he was a young person. He, had done some bad things, and you might say, well, we deserved it. But of course, physicians, we can't. So I just went to work a little bit at a time, step by step, freeing this adhesion, identifying that structure, thinking all the time is that this is impossible, but I can't. Eventually, we managed to identify the structures and fix them. So that was one of those cases that they don't know what happened to the patient. I do know he recovered and made it out of the hospital. I hope that after that he had better kind of go in life. But
Switching gears to non-invasive vascular labs, not many people know that we have one of the oldest vascular labs in the country. Could you walk us through back in 1985 when vascular ultrasound is not that well developed, there's no criteria, there are one or two labs in University of Washington. What went through your mind to establish a vascular lab, and how do you figure out that that's the way for future back in 1985?
Well, the answer to that is two words: Marcia Newmeyer, who was one of the early creators or inventors, if you might want to call that, of non-invasive vascular testing. Marcia had been a pupil of Gene Strandness, who was a vascular surgeon practicing in Seattle, Washington, who basically had invented, or at least was one of the inventors of non-invasive vascular imaging. Marcia had worked with him and learned from him. He was a very apt pupil and quickly became herself one of the renowned experts testing, and she was at Hershey Medical Center and a lot. Established our vascular laboratory, grew and created some new things and developed some new techniques. Really, you can't practice vascular surgery without those. To give Marcia, all the other folks who have participated in developing be able to be part of that and acquire those skills.
Adding on to that, how, because the carotid criteria are all based off of Strandness criteria, but they've had some changes. So did you and Marcia do that? Did you guys kind of, were able to kind of tweak the criteria to make it applicable to Hershey patients, other patients in this area? Or?
We did, but I clearly want everybody to know that the credit for that goes to Marcia. I was kind of a bit player in that. I made some contributions to it, but Marcia really, that was her passion at that stage of her life, and she threw her body and soul and heart and all the resources that she had in order to be sure that the technology was developed in the right way, made such that it could be done easily and non-invasively and successfully for the good of the physician and the patients both. So it was a great privilege to work with Marcia and learn from her. Still keep in touch, and Marcia, bless her heart, is in her 80s, but she still travels around the country and actually around the world spreading the gospel, non-invasive acid. Force to reckon with.
So, when you trained at Mass General, did you guys have a vascular lab there, or during your training, or no?
Very rudimentary. Just the very, very beginnings. We're going to pick up on that. Really,
Okay.
the early inch. Really, nobody really relied on it.
Mhm.
The promise of it did not realize.
So how difficult was it to incorporate it into your new practice, at this institution while you were developing it, really? I mean,
That was easy again because Marcia was me and she had already established and gave me my orders, and I was so that all went very smoothly and developed without much input.
Mhm.
I tried to do my part, but that was her area of expertise. She took the ball.
Oh yeah.
I have another question for you. So as surgeons, complications happens to all of us. And we do discuss in our M&M conferences what happened to the patient. But I think one thing which we don't realize as surgeon is there's a trauma to the patient, but there's a trauma to us as surgeons, as human beings as well. We don't discuss that in M&M because we do take our griefs, we do take that heaviness in our heart back to our homes. What's your advice for all of us, especially for younger faculty and younger residents? How do you deal with that? The secondary trauma which happens to us, which we don't discuss.
Now you're asking me the hard questions. It all depends on who you are and what your emotional makeup is, and how you handle difficult problems and situations, and how you go about trying to solve them. And that's a little bit different, whoever you are, and whatever your life experience has been, and what your kind of overall outlook on life is. I've always been a person who wanted to be closely involved in patient care. Didn't want to do it at a distance. They tell you don't get too involved with your patients. In a certain sense, that's right. You don't want to get emotionally involved with your patients, but to be involved as a caregiver with a patient is, I think, what you definitely should do. You want to not only take care of your patients, but you want to care for them. That involves going more than skin deep, trying to learn more about them and about their life and about their goals and about their hopes and desires and what their personality is, how they solve problems, what do they worry about. Some people worry about everything. Some people really don't worry about anything. Your patient, if you can stop your patient from worrying, they're going to get better quicker. Your patient is mired in worrying and fear about what's going on, utilization, and keep them from getting well. So one of the things that I enjoy doing most in practice of medicine is pulling up a chair next to the patient's bed and sitting down in that chair and taking whatever time is necessary to find out what's going on in that patient's head at a particular time. Now, if you go in on rounds to see the patient and the patient's smiling and they look comfortable, eyeball test suggests that they're doing well. You don't necessarily need to spend a long time at that patient's bedside talking to them about the world and all that sort of thing. We're all human beings are born and develop the ability to look somebody in the eye and know whether there's something wrong. That's what you do when you go into the room. You look at the patient in the eyes and you can tell immediately. First of all, you can tell if they're about to die. Second of all, you can tell whether they're worried, whether they're feeling good, whether something's on their mind, whether they need to talk to you. You need to pay attention to those things so that you can take the time to sit down at their bedside and your incision looks good, but something's bothering you. What is it that's wrong? What are we not doing? What are we not? Rounds are going on and you're feeling the pressure to move on to the next patient and, so that you can get to clinic on time or you can get to the next case on time, but you can't do that. Some people that just demand your attention without saying a word just because you can look at them and tell them something needs to be addressed then and there. So some people will tell you not to get too involved with your patients, as I said before, but I was never able to follow that rule. Not that I had long, intimate conversations with all my patients every time I went on round. But I think that you need to preserve the ability to sit down with the patient and give them more time than you expected you would have to, because you can tell that they don't need a pill, they don't need an injection, they don't need an IV, they need you. Sit down to them, find out what's going on, why they don't look right, why they don't feel right. Be sure that the patient knows that you care about them. Continue to care about them to the best of your ability until they can walk out.
Thank you, Dr. Atnip. In the interest of time, I'm going to open it to audience to see if anybody has any questions.
Question is, all the hard work and hard training, healer, mentor, what inner purpose, especially in the moment?
So I think I have to start by giving a lot of credit to my upbringing. I don't want to dwell too much on this, but I had what I would consider to be the best parents that a person could have, who taught me what love was, who taught me how one person should care for another person. Took me to church a lot, so I absorbed a lot of good things from them. They sent me on my way, I think, well equipped to do the right thing. Not to say that I always did the right thing. We can talk about that later. Give them primary credit for my upbringing, my teaching to care for people, to not be selfish, and to render attention and care to other people who need it in order to make their lives. And so sometimes you can succeed at that, sometimes it's always been kind of a bedrock value of mine. If there's a way you can help somebody, do it, or at least try to do it. I think that's one reason why I decided to go into the practice of medicine, but there are people who need help. And the human body is a fascinating entity. To be able to help heal the human body is a remarkable thing, the fact that you do it. a remarkable, challenging thing. Something challenge that I felt we want to take on here. So I think that's the bottom of it. It's simply the need for one human being to take care of another human being. You were able to do that. Just, I guess, something that was ingrained into me, fortunately. I had to be reminded. I still have to be reminded. Should be number 1, 2, or 3 in your priorities when you deal with other people.
Any other questions from the audience?
Ask you, what kind of advice do you have for the trainees and those new graduates in order to develop their practice within a community? And then my other question is, how do you deal with physician burnout, those especially like started in practice?
What was the first question?
What kind of advice would you give to the trainees and newly hired physicians in order to grow their practice within the community?
Sorry, I still. Okay. I guess number 1 is to be a good doctor and obtain a good reputation. Starting point. Being spread by word of mouth. If you're a good doctor, friends and neighbors will hear about the fact that you have a good doctor. I think that's a very important thing. I think that's the most important thing, really, is just do the work that you need to do to obtain a good reputation and help as many people as you can. Spread the word. Burnout is real. I don't like the word. I think it's overused, but I understand what you're saying. It's basically I guess it's as good a word as any. Combination of fatigue, emotional stress, fear of failure, all those sorts of things that make you ask yourself, should I be doing this? Am I doing this well enough to suit myself, and am I doing it well enough to provide the help to my patients that they need? Do I have the knowledge I need? And I'm going about this the right way? It's all those questions that you ask yourself as you go along. Sometimes it involves how other people see you, whether you think other people like you or not, or what you do is pleasing to other people, satisfying. There's a lot of different things that do that. So the phenomenon is real, whatever you want to call it. You get tired sometimes. You have a stretch where it seems like every patient you get is a difficult patient, and no matter what you do, seem to respond to the treatments to them. And you begin to think that you don't have the ability or the skill or the judgment doing that. You feel like you're a failure, no matter how hard you try. I think the first thing you have to do is try to analyze what factors are involved in that, and what is the thing that seems to be the biggest factor your dissatisfaction, things are going. Try to analyze. Usually it's one thing that's festering, something that you tried to swallow or bury or ignore, or underestimate impact that it might be having on you. Sit down first and kind of analyze yourself first, and ask the folks that are closest to you, if they haven't already said anything to you, like, what's wrong with you these days? But you can say that to them. You can go to somebody who's close and say, something is wrong. I'm not myself. What do you think? Have a long talk with a confidant, somebody that you can trust. Kind of bounce things off of them, see if other people feel that you have changed or that you seem struggling. Figure out whether it's just you that's having an episode of loss of confidence, or whether it really is a problem that other people have noticed, that you're not doing well and other people think the same. Basically try to get down to the bottom of it and figure out what is it that's really causing this, and who can I talk to? What can I change? Maybe, look back eating weeks or days and try to figure out, when did this start, and is it my work or is it something else? Is it a relationship that's not going well? Do the best you can to make a diagnosis for what's bringing you down, and then if you can do that, talk to other people. Try to work through it. By all means, if necessary, seek professional help or seek help from a family member or someone. But the bottom line is, don't just bottle it up and wait for it to go away. Sometimes that works, but most of the time it goes on for more than a few days, or certainly more than a week. You really need to do something. You need to talk to somebody. You need to get to the bottom of it in order to identify the primary issue and work on that, or at least make a plan about how. Certainly you don't want to just bite your lip and say, well, I just need to be tougher, or I need to be more resilient, or it's just a phase I'm going. Maybe it is, but if it continues to go on, be honest with yourself. Whether you really have a problem. If you do, then you need family, or don't ignore it by all means. Ignore it, or don't think that it's normal that it happens to everybody. To be honest with yourself.
Thank you.
So, end of Rock Center, he knew that something different, that he was all. He had a discussion. What do you do next? Wasn't ready to stop, and so he all went. Well, can I still be a vascular? Says no. There. So he transitioned into, which was really good fit his skill set, and it addressed the current and so another alternative in burnout is a little bit different.
And that time comes in every career when you aren't at the top of your game. And I think that's one of the most difficult. My observation of older physicians when I was a young guy, I would kind of look at my older colleagues and kind of see how they handle things, particularly as they got older. I was kind of reaching, midlife and wondering, okay, how long can I do this and so on. So not too difficult to look around at your colleagues and kind of assess how they're managing it, or just ask them point blank, how do you think I should handle this? I think growing older in the practice of medicine is a difficult thing to handle because, again, you've been doing something, you've been doing it very well at the top of your game, and time goes by, and suddenly it's not that easy. Or easy to get into denial that days and go. But for me, it was, I don't know, it happened over a period of maybe weeks, maybe even months, when I just realized that I wasn't as engaged doing what I was doing as I used to be. I just knew that trying to push myself and just, trying to do what I had been doing when I was 20 years younger was not a smart thing to do for me or my patient. And I didn't, quit. I just kind of gradually, slowly took my foot off the gas pedal. And remain, be able to keep being a healthcare provider, but to do it in a different way, in a different circumstance, a way where I could still fulfill my professional desires and abilities, help patients. And there are sometimes counseling, talk to a colleague, talk to a professional, do what you need to do to work your way through that position. Because it's hard, and I've watched many people do that, and then I went through it myself. It's don't just say, okay, I'll wing it. I can do this myself. Probably you can't do it yourself. You can't make that kind of decision all by yourself. You need to talk to other people and bounce things off your colleagues and your family, and let them help tell you whether those emotions are real, whether they're just transient, or whether you really are ready, to make some kind of big change.
Thank you, Aaron. Thank you. Any other questions before we go on? Hey, yes.
And I worked underneath Dr. Atnip. He was here when I first came to Hershey in 2001. Excuse me. And he was, and still is, I'm sure, an excellent vascular surgeon. He was someone, you were a mentor to me. You were someone to be respected. And I wanted your respect. I am a pleaser. I'm a nurse. And looking at how you practice and how you took care of your patients, I wanted to earn your respect. So you motivated me. You motivated me to become a better nurse. And I thank you for that. Watching you practice over the years, watching how you did your assessments, watching how you even got your pedal pulses. I tried to copy that and learn that. And I thank you for motivating me and teaching me to be a better nurse. So thank you.
Thank you.
Mm-hmm.
That's really extraordinarily kind of you to speak up and say, great working with you and with all the nurses that I have come into contact with, and worked with over the years were extraordinary. Couldn't have done anything I did without all the other healthcare professionals that we, certainly the nurses are the most important. Thank you for helping me.
All right. Thank you so much, everybody, for spending your afternoon with us. Really appreciate it. Thank you, Dr. Atnip.